guys able to see the screen? Yes? Yep. All right. Thank you. No problem. So the scope of this presentation is primarily to help you use ultrasound when you're scanning lung, what you look for when you're looking for pleural effusion, to help you diagnose pleural effusion, to diagnose pneumonia. We're looking for the normal, how the normal lung looks like. And we're going to go through a few cases, and I'm hoping that you're going to participate to, how ultrasound helps in decision making. Okay, so when do I use ultrasound? Primarily for shortness of breath. So that can be, shortness of breath is a big umbrella, and it can be, again, can it be cardiac cause, or can be, let's say, respiratory cause? Is it pulmonary edema, or is it COPD? And definitely the ultrasound can help you with that. It helped me in sepsis, for example, when I'm looking for a particular source of, if I have someone in sepsis or in septic shock, it helps me very easy at the bedside diagnosis that pneumonia is the culprit, apart from the history taken. Helps me diagnose pleural effusion. And again, it takes a minute to do that, and also to make decision if that pleural effusion needs to be drained, or if it doesn't, if it cannot be drained. It helps me in chest trauma, particularly diagnostics in hemothorax. In thoracentesis, helps me guide where to put the needle. So I use the ultrasound to guide which intercostal space I use, because you don't want to put the needle when is through the liver. So again, when you do a procedure, diaphragm migrates with respiration, and we think that the fifth intercostal space is the safest one. However, sometimes if you have a diaphragm with hemidiaphragm paralysis, that diaphragm can be at the fifth intercostal space easily. So you can enter in through the liver and do more harm than you intended. Helps me diagnose pneumothorax, and also I use it in cardiac arrest, particularly looking for the causes for the HNTs. Okay, so tension pneumothorax, hemothorax, or cardiac tamponade. So there is a lot of usage for the lung ultrasound. Okay, the probe that I use, they're both curvilinear or the linear or the linear probe. And where do I place the probe? I place it basically where I use with the stethoscope, anteriorly and posteriorly. And there is an advantage for each of them. So anterior chest, particularly have someone in supine position, it helps with the pneumothorax. When you put posterior, it's for pleural effusion or edema. Okay, and the lateral way is also on the lateral, so mid-axillary line, it helps you with effusion or diagnosing consolidation. So coming back, so I'll use it again where you use the stethoscope. So anterior, I use 3 probes. Okay, 3 sides on the left side and 3 sides on the left side, and then I'll go posteriorly, 3 spots. Okay, and that's basically, it takes about 3 minutes to do the scan, because you go very quickly through it. Okay. The next thing we're going to talk about how the normal lung looks like on an ultrasound image, and then we're going to have some images. So there are a few concepts that I'm going to introduce, and that is called the A-line, comet tails, and lung sliding. So these are primarily the 3 big things that we're looking to diagnose if its lung looks normal or not. Okay, and we're going to go through each of them. Again, if you have any particular questions along the way, ask me, because sometimes I speak too fast, or you might not understand my accent, or there's just you have questions, or there's certain things that you're you're querying more. So if you want more clarification, please interrupt me. Okay. Now, this is used a curvilinear probe. Okay, so you see it's very wide window. Okay, and this is, I'll keep playing this that loop. Okay. Now you see here 3 lines. So this is the pleura, the white. You have skin. I'm just going to go through the anatomy. You have skin and subcutaneous tissue. You have 2 ribs that are giving you black shadows here and in this area. And in between, just underneath it, this is the pleural line, we call it. All right. So underneath you see another line, white line, and another one. That is also pleural line, but we're going to go through it because it's actually a mirror effect from reflection from the lung. So pleura, it's only here. Okay, and this is how it normal looks like. So this is called A line. All right. So this horizontal line. Coming back here, so we'll have, this is using a flat probe. What you see here is pleura. This is subcutaneous tissue and muscle, and some subcutaneous fat. Okay, and this is pleura. This is rib here and here. I put the image here as well. Okay, so this is rib. You see hyperechoic, and then a black shadow underneath. This is rib, and in between you have you have here pleura. This is A line, and that is coming back. The A line is, let's imagine that you put a mirror, 2 mirrors in front of you, okay, and you put a source of and you put an image in front of it. So that image and the light goes into the mirror, and then it bounce into another mirror, and you get this. When you look at the mirror, you'll see multiple images, the object, and multiple mirrors down. So you have the sensation of depth. So basically the same thing happened with the ultrasound wave. It comes from this area. Okay, so it comes from the top, goes through the tissue, which is echogenic, so it allows the wave to pass through and hits the pleura. When the ultrasound wave hits the air, it reflects. So the ultrasound wave does not go through the air, and therefore it goes back towards the ultrasound probe. And then when it hits the ultrasound probe, bear in mind it is air in this area as well. It bounces back through the skin, travels back towards the pleura, and therefore hits air as well, and bounces back towards the skin. Does it make sense what I'm saying? And therefore you have what you see, the images of A line. You have pleural line here, and if you increase the depth, you'll have multiple pleural lines. Probably this is the hardest thing in this whole lecture to grasp, okay? How the waves behaves when it hits the air, okay? So coming back, ultrasound waves coming from the top, goes through the tissue, which is echogenic, hits the pleura, and then it hits the air. When it hits the air, doesn't pass further. The ultrasound wave goes back towards the skin through an echogenic, okay? And therefore the mirror effect is, it feels like the air goes further down, the ultrasound wave goes even further. But when it hits, the air bounces back and it hits the pleura, then comes back again. So the ultrasound wave is doing this, coming back towards the pleura, and then bounce it back to the air, and then bounce it back towards the pleura. And here it creates again the mirror effect. So this is the pleural line here, okay? All right, so that is part of the normal. Coming back, this is normal A line. So this is one aspect of the normal lung. Okay, any questions about that? Because we're gonna go to the lung sliding as the next one. No? All right, so lung sliding, it actually refers to, all right, this is more magnified. So we just zoomed in into this pleura. Okay, so as you probably know, you have a visceral pleura, okay, and you have an external one as well, parietal as well. So we have two, the pleura has two sheets, yes, a visceral one and a thoracic one, okay. Now, in between it, you will, so they slide, so they don't go in the same direction. You will see it going, one goes in one direction, the other one goes in the opposite direction. Okay, so they slide. Okay, they're like two. I'm not sure if you see me as well. I might. Shall I stop? Can you guys see me or not? So
We can see you.
you can see me. All right, no problem. So, the lung sheets, they are doing like this. Okay, they keep doing like this. So this is the visceral pleura and this is the thoracic pleura. Okay, so they do this, and that's this thing that you can see it at the level of the pleura. Okay, all right. The thoracic one moves on top of it, and you'll see also. Okay, now that's all going to go to the comet tail. So at this level, so this is at the level that we are looking at. Okay, to see the lung sliding. Okay, and you'll see it moving in this direction. It keeps, and that's its movement with the respiration. Okay, no problem. So coming back, and this what you see is the white, little white blobs coming downwards is the comet tail. So comet tail is little artifacts that are created by the visceral pleura. So the lung itself, you have alveoli here. Okay, so this is skin, this is the parietal flora, and this is the this is the parietal, and this is the external thoracic one. So you have here the ultrasound waves coming through. You have, this is a visual, a virtual space. It's not, the pleural space is not so big. It's actually very tiny. But underneath it, the parietal, the visceral pleura, you'll have a little bit alveoli and a little bit of air. A little bit of fluid in between alveoli. And therefore, this one reflects in such a way that it gives you this kind of artifact. Okay, so these comet tails is actually also part of the normal lung, and it shows that you would have normal alveoli in this underneath it. Okay. Coming back, lung slided, you're looking at this parietal thoracic pleura and also visceral pleura, how they move on top of the other. And then you have the comet tails that are coming artifacts from reflection of this alveoli. Okay. So coming back now, so we talked about the three aspects of, this is here a little bit more comet tails, the three aspects of a normal lung. Okay, because you will have, when you have different pathology, you'll notice the absence of them. Okay, so this is subcutaneous tissue, and this is pleura. Here, you see the lung sliding, and you have little comet tail. This, and this is the A line. Okay, this is again normal ultrasound. Sometimes settings can help. So coming back here, you see this was much more crisper than this. Each machine can have lung settings as well, so they can make it the image a little bit more crisper. So sometimes you have vascular or soft tissue settings. Have a look at your machine if you have lung settings as well. coming back here. Let's recap. So you'll have subcutaneous tissue and muscle. This is the pleura, the big white line. Underneath it, this is A line. Okay, and bear in mind the A line are the same distance between pleura. So A line is the same distance from here to here if you measure it. Okay, so it should be not to get confused. If this one initially I thought maybe it's this one A line, and actually it's not. It should be the same distance here and here. Okay, this is how you know that it is an A line. On this loop, there's the same subcutaneous tissue, pleura. This is the A line. And then you'll see the lungs line. You don't see much comitails, but you'll see the lungs line. Maybe here you see a little tiny comitails, but you'll need a little bit more. Might need to zoom a little bit more. Okay, so this is like ants, with also it's called ants, walking ants in this area. And that's why it comes, that is like tiny comitails. Okay. I'll come, if we have time, to the pneumothorax. So all talked about is normal lung because it helps with diagnosing of pneumothorax. But I'll come back more towards the end of the talk because I thought actually it's easier to talk about a few cases. And if we have time, we'll come back to pneumothorax. All right, so let's go through the case number one. So you have a 30-year-old male with scapular pain, and he was recently admitted in the hospital with dilated cardiomyopathy. He has no shortness of breath. He had vital signs of heart rate of 115 and saturated 98%. He had abnormal ECG, but someone did a D-dimer. Now, I'm not sure if you guys use D-dimer. In Australia, it's used for example, as a screening tool for pulmonary embolism. So someone thought that this gentleman had pulmonary embolism, therefore did a D-dimer, which is 3, which is very, very high and very abnormal. Again, D-dimer is not a great, it's not a great diagnostic one. It's more of an exclusion workup of blood clot. But if someone had D-dimer 3, can be anything. So let's have a look at the images and see what comes out. All right, so this is his heart. So this is in a parasternal long accent. And you'll have here very big heart, very poor contractile. So it has quite severe dilated cardiomyopathy. Bear in mind, we're talking about a 30-year-old guy who has dilated left ventricle, dilated left atrium, and the heart is contracting very poorly. It's very weak. Okay. Now, when you look here, we'll have a look through the lung ultrasound. So this is the liver, the diaphragm, and here you'll have. Okay, so this is part of the lung. So you have here the pleura. Okay, and then let's go back through, scan through again. So here you'll have normal, again, this is done with the curvilinear probe. So you have quite a bit of depth here. But you see here, this is the pleural line in this area. Okay. And this will be then A line done. But basically what you'll see abnormal in this area is actually, you'll see all these white beams coming in. Okay. Like various sunshine rays. Okay. Now, as you remember, when we talked about normal lung ultrasound, this one, we didn't talk about this aspect, okay? Because that is not normal, this is abnormal, and we call it the B line, okay? And it's a sign of pulmonary edema. Now, if you do snorkeling or if you do diving and you go under the surface of the water and the sun rays go through the water, they have this kind of appearance, like in this image, okay? And there's the same thing, what happens with the lung. So early on, when normal ultrasound, it has air in the alveoli and it bounces, doesn't allow the ultrasound waves to go through. But when you have filled with water, the ultrasound waves, they go through the lung now, so that what we call it, the lung becomes echogenic. Okay, so that is what we were referring to, increasing echogenicity of the lung. And let's go through the next. All right, so coming back, what are the B lines? Okay, so there are specific criteria in terms of the definition. So they are vertical artifact rocket likes. Okay, let's go through each of them. All right, so you will see how the difference, this is, we are talking here, you were using a curvilinear probe. This is not, so it's a lot of depth. You see here 17 centimeter. So that's a lot of depth. We are not talking about the flat probe, which we have like 2-3 centimeter depth. This is 17 centimeters. So these are so this is different from the comet tails. Okay. Now, you'll see how there's very long beams. Okay. And they get wider, they come from the pleura and they fill up the whole screen. Okay, they're like lasers. And they don't fade. Okay, so they don't lose with the depth, they don't use the contrast. They move with the respiration. Okay, and we talked about A-line. I'm not sure you might see. So this is the pleura. This is subcutaneous tissue from the top, pleura. We might see some A-lines, maybe here or maybe here. Okay, but it's a little bit, bear in mind, and you have this B line who completely crosses the screen. Okay, and that is because you lose, most of the time you lose the A line because you have suddenly a lot of water in the alveoli. Okay, the more beams you have in one window, that means the more edema it is. Okay, and theoretically you need to, if you have the three beams, okay, lasers like, then you will have quite significant pulmonary edema. So coming back into, in your patient who comes to emergency department with a shortness of breath, and you suspect, you don't know if he has pulmonary edema or he has COPD, once you see these B lines, that is, it is very pathognomonic for pulmonary edema. Okay, and that's, you're not going to treat him as COPD, but you're going to treat him as acute heart failure. Okay. Questions? I think probably that is, if there is something very useful for you guys, I think diagnosing as a practice pulmonary edema is one of them. So I'm hoping that if you have questions about it, please ask me now. Hello? Hello?
Hello.
Okay. I don't know if I see no one, so that's why I'm not sure if it's disconnected or it is or it's only if I'm still online or if people are still online.
Hello. I have a question
Yes.
for the type of probe. Are we only using the curvilinear when we want to diagnose, or we're thinking of pulmonary edema, or we can use other probes for this?
Yeah.
And the criteria.
So to see the B lines, you will need a curvilinear probe, because with a flat probe, you're not going to be able to use to see it properly. You might because it's how to put it, the depth is not big with a flat one, with a soft tissue probe. My recommendation is to use the curvilinear one, the abdominal probe.
All right, thank you.
Okay. You can use the cardiac probe if you're familiar with it, or if you're using cardiac probe, that you can use that one as well.
Okay.
But for to make sure that that it's to diagnose the B-line, I would recommend you to use the curvilinear one.
All right. Thank you.
Okay, no problem. All right, good. Now, case number 2. So this gentleman came with, so he's a 78 years old gentleman, came with shortness of breath. So he was admitted in the hospital for blood transfusion. He was found, he didn't have much medical condition, but he had, he was anemic, was found to be anemic, and he required blood transfusion. So within 2 hours of this blood transfusion, he started becoming short of breath. He was not able to lie flat. He became tachypnic with a respiratory rate of 30, started requiring oxygen. His heart rate started increasing, and so does blood pressure. So he had a chest X-ray that it looked like this, and it didn't. So at that moment, so it didn't look like any consolidation or pulmonary edema in it. But again, chest X-ray is not very. In the early stages of acute pulmonary edema, it appears normal. Okay, so just bear in mind that a chest X-ray, it has its own limitations as well. So I was looking for, again, I had a look at his lung, but before we move along, anyone has a particular thought about what might be the causes for the shortness of breath, or can give me a differential diagnosis for it? So, for example, 2 things that might, in this scenario, might be the culprit for his shortness of breath.
APO and possible, given the acutness, it could be thinking first top of the list with the APO.
Yes, APO, yes. So he didn't have kidney problem, he just had anemia, that's all. But it can be, yes, acute pulmonary edema from left ventricular failure, yes. For heart failure, any other different cause for it?
Anaphylaxis?
Yes, acute blood transfusion reaction. Yeah, correct. So blood transfusion reaction is another one, okay? Correct. So now, and that is something that I was looking at to see, does this gentleman had an undiagnosed undiagnosed heart failure that never, he never complained about, and was it blood transfusion reaction? So I had a look at his heart first. Anyone wants to make a comment about it? And this is his lung ultrasound. Okay, so I did you can see the lung ultrasound. You see this. This is again curvilinear probe. Okay, this is pleural line, and we have quite a bit of B lines. Okay, so he has edema. We have fluid in the lung. Okay, you'll see how many B lines are there. 1, 2, 3, 4, 5, 6. Okay, all right. And what about, think about this heart? Does it look like a heart failure? Early on, I was showing you how the echo with the heart failure, and it looked very, so this is substernal window, but it looked very dilated, very poor contractility. This is more hyperdynamic, so the heart contracts quite quickly. And the left ventricle is this one. You can see that it's nearly touching, the walls are nearly touching itself. So it has a very good contractility. So this is not heart failure. Okay, so this is look like a normal heart, but this. So coming back, what can be? So heart is not. It's not heart related. So we call it non-cardiogenic pulmonary edema or acute lung injury, and it's related to blood transfusion. Okay. So coming back, we talked early on about heart failure, and if it is lung ultrasound using it, is it heart related or is it lung related? And in this case, I'll call it acute lung injury. Okay, so the treatment for this fella is stop the blood transfusion immediately. Okay. And most likely this guy is going to get sicker and sicker and might require intubation. We're going to move to the next case. Do you have any questions about this? No? All right, let's go through this another case, and that's a different pathology. Okay, so we had someone who overdosed, and he was in altered conscious state. We had brief CPR. He was hypoxic, and he has some chest pain. Now he had a chest X-ray that it looks like this. So you see some haziness in both lung fields. Okay, you have on the right and on the left. And then on the long ultrasound, it looks like this. So this is sternum. So this is along the sternum, so the longitudinal view of the sternum. So you'll see here, this is the bone. It's hyperechoic. Okay, but you'll see here the fracture of the sternum. So this step here is it's a break in the cortex. So this is this is a flat probe used. Okay, where you see soft tissue. And then you have the bone with a break here. Okay. Now, looking at the right base, it looks like this. So this is, in this area, you have the diaphragm and the liver. Okay. So this is lung. Okay. So coming back, this is completely different from image from the normal ultrasound. So I would say that is abnormal lung. Anyone wants to have a go? What might be? Given scenario.
It looks like bronchograms or something.
Sorry?
Bronchograms. Those white what you call
Hyperechoic,
it?
hyperechoic. Yeah, so you'll see here hyperechoic structures. Yes. Okay. All right. You can't quite see the pleural line, probably it's somewhere in this area. Okay. But you cannot see the A line. You can't see the comet tails. But you see a lot of echogenic. So you can say that it's echogenic. Okay. All right. So you have an increased echogenicity of the lung. You can start seeing, basically, you can start seeing through it. And in the middle of it, you have this white blobs, which is air. All right. So this is how the pneumonia looks like. And this guy has aspiration pneumonia. Probably he's became hypoxic, became hypoxic because he aspirated when he was in altered conscious state. Okay, so coming back, this is diaphragm. All this is air in the alveoli or bronchioli. And then you have areas with consolidation. So you have area with liquid in it, with edema. You might not have the typical B-line aspect that we talked earlier on, but you have some of the lung is collapsed, some of the alveoli is collapsed, some of the alveoli is filled, okay, with liquid. But the typical aspect of it is that you have air, which is this white hyperechogenic. Bear in mind the air reflects it. So, but you go through an echogenic structure as well. So that's why it appears as white aspect, okay, because it reflects. We call it hyperechoic. Okay, so this is, and it moves with respiration. So these reflections of the waves that appears as a very white structures. This is if they move the respiration, it points towards aspiration, towards pneumonia. Okay, so you have air in the bronchioli and in some of the alveoli. Okay, So coming back now, how do they look? So on the pneumonia on the chest X-ray appears, for example, as a consolidation like this. But this is a typical aspect of a pneumonia on the ultrasound. So this is the spine here, and then you'll have increased echogenicity of the lung, and you'll see how the air goes through in the bronchioli, and that is when the air, when you take an inhalation, air comes in the bronchioli, doesn't reach the alveoli. It's just in the bronchioli, and that it comes out as a increased hyperechoic. Okay. I hope that that helps you with the next pneumonia patient. Now, the next condition that is very used, the ultrasound is very useful to use is diagnosing and pleural effusion. Okay, and differentiating between from a consolidation. So, look, I'm sure you guys seen very advanced lung, infections or TB. You see tuberculosis a lot, and sometimes you wonder. You see probably quite more frequent, X-rays like this than I do. But sometimes you can have. You don't know how the lung looks. Is it malignancy? Is it pleural effusion? Is it a very large consolidation? Is it an empyema? Okay. And that's why the X-ray might not help. CT, yes, it helps you, but sometimes it's very difficult to get access to it. So lung ultrasound is very, very useful. And pleural effusion, it appears like this. Okay, so this is coming back curvilinear probe. Again, the advantage is that you have a lot of depth to go through. This is the hilum and this is the lung, and you'll have diaphragm is in this area. And this black structure here, as we call it hypoechoic, actually is fluid, okay? And that is the one, this is a large pleural effusion. Coming back, this is collapsed lung, so that's where I started seeing it. This is atelecta lung that has been compressed, and therefore all the air has been squashed out, and therefore it becomes this way. All right, so you start seeing it. And this is large. So you would drain, this is a very good spot to drain pleural effusion. More pleural effusions, okay? So we're gonna go, this is the liver with diaphragm. Okay, this is the lung, and this is pleural effusion. And this is the spine, okay, that you use it to differentiate, yes, you're in the right spot, and you'll see this is called the spine sign. Now, let's have a look on another video. This is lung coming back, subcutaneous tissue, muscles, okay? You will have ribs sitting on the side, and then underneath you have this black, it's hypoechoic fluid. This is lung, and the white part that you see, it's some bronchiola and airways, part of the airways as well. Okay. More pleural effusion. So sometimes you'll see, sometimes you have fibrous tissue. Okay, so you see how it is. It starts from forming fibrin. So not to get worried about it. Sometimes you'll see it even more, fibrous, and you have like a spider net in. Okay, so this is a pleural effusion that has, probably had a high protein contact, and therefore starting organizing it. Right? Sometimes when you drain, you might not get a lot of fluid out of it, but you might try 2-3 spots to drain as much as fluid. So don't get inhibited seeing this, that, oh, maybe it's not fluid. No, it is pleural effusion with fiber organization in the middle, inside it. All right, what about this one? So this is, again, diaphragm, liver here, and this is, it looks like this also. Where do you think might be? This is the heart that we see in the background, and this is lung. And this is part of the airways as well. Okay, anyone wants to have a suspicion what that might be? And this on the left side or on the right side? So you don't see it like a very, you know, we saw early on is very black, very echogenic. This is the density of the fluid. It still has fluid in it. You can see it moving.
Blood.
So, yeah. So one thing, it can be blood. Exactly. So you see it is not how we had it in this image where you have very echogenic. Okay. It goes, you have a blackness. Okay. And that is something that you have no tissue in it. You have no blood clot in it. In this situation is you will have, okay, it becomes more tissue. It has the echogenicity as a tissue. Okay. And sometimes it can be blood and it's still swirling around. Okay. Sometimes it has a clot in it. You'll see this, the echogenicity inside you have has increased, it become tissue more like echogenicity. So this is the blood clot with the fluid around it. Yeah. Another thing can be pus as well. So think in mind that sometimes it can be empyema as well. All right, so we had, this is an interesting case that I have a 51 years old gentleman who was brought, he was found bedbound. He was using drugs nearly every day. And he was found in bed, unable to move. He was complaining of shortness of breath, cough, lot of sputum. He was not, his numbers was not too bad, but he looked terrible. He was looked very cachectic. So giving drug use, initially I thought it might be, it might have endocarditis, but this might be a tricky one to pick it up. Just all right. So this is the heart. This part is the liver. Okay. But what I was noticing that in this structure, there is something that compresses the left ventricle. Something in the lung compresses the ventricle. Okay. This is echogenic structure here. Tissue more like you see. I have it in this image here as well. All right. But I'm hoping that this, he had a chest X-ray that looks like this. So anyone has suspicion what might be? Or let's say on this chest X-ray, it looks like a looks like a pleural effusion. Okay. So when I had a look at the lung, again, that is for the left base, it looked like this. So this is curvilinear probe. This is here you have the shadows from the ribs. So this is rib. This is a pleural line. Okay. And there is this structure here that is in the lung that is echogenic, tissue-like. Okay. And then you have some white hyperechoic structures in the middle of it. Okay. What do you think might be? Who wants to have a try? So coming back, was this something that you drawn? Do you think it's a pleural effusion, this one? Do you think it's a consolidation? We talked earlier on about pneumonia because you have that hyperechoic structures in the middle of it. Do you think it is hyperechoic? It might have a consolidation.
Between the sign of consolidation and this one.
Yes. So what's the difference between the consolidation one when we had a look at the consolidation? Because let's refer the hyperechoic structures, the white thing that, what is the difference between that one and this one?
I think with consolidation, we've been seeing it like the reflection was mostly when the patient was breathing and breathing out.
Yes. So they are dynamic, correct?
And
With the respirator. Yeah.
And also they are not spread like this one. They are more localized, sort of.
Yes. Correct. Excellent. Yes. All right. And what was we talked earlier on about so it's not a consolidation. Coming back. All right. This is not a consolidation. And we talked earlier on about how the lung, hemothorax looked like in this image. Okay. Where was it? I think it was in this one. You remember that we talked, if you see that, you see this, the same kind of echogeneity. If you look on this, yeah. The echogeneity is kind of the same. So with this, yeah. So this is empyema, actually. Yep. So you have the fluid inside. It has more consistency. Probably that is the word. And the white part in it is there are some bubbles of air inside. And I'll show you the image of the CT. The CT looks like this. So this is the lung, and this is part of the kidney, but lung was pushed, collapsed. So this is the empyema here. It's a big collection, and you have air in it because all the bacteria, they produce air as well. Okay. So therefore you have this is a typical aspect of a empyema. Okay, try to remember this. So this is once you, let's say, if you're worried about draining, this is something that you based on the ultrasound, you can put the needle in and drain it. Okay, and put the needle in, and aspirate and see, what comes out, and you'll see pus coming out. Yeah, comparing with when we talked with consolidation, where you have that dynamic aspect with inspiration and expiration. Okay, where you wouldn't want to drain that. Okay. Any questions? Because I think it's, what was it? It's 10 minutes, 8 minutes to 6. So I think I'll stop here and I'll open it for discussions. Because coming back, we discussed today about normal lung ultrasound, and we talked about comet tail, A-line, and the lung slanting. This is the 3 things that to look at when you do the scan. And we talked about the A-line. This is, again, you see that parallel to the pleura. A-line is plural. It's a line parallel to the pleura. Okay, but it is an artifact, so it is a reflection of the pleura, actually. And that disappears when you have pleural effusion, disappears when you have consolidation, that disappears when you have pneumothorax. So if you don't see the A-lines, start to be suspicious. The normal one was also, we talked about comet tail, and also we talked about the lung sliding. Now, in terms of pathology, we talked about pulmonary edema. That is the B-line, the long beams, okay? We talked about ARDS, okay, when you look at acute lung injury, okay, where you have a normal heart, but you have a lot of pulmonary edema. So think about acute lung injury because the treatment is completely different. Talked about consolidation, and that is you have the increased echogeneity of the lung, but also you have the dynamic hyperechoic structures, which is air in the bronchioli. And then we talked about pleural effusion, which is the hypoechoic structures that you can drain if you have a large amount, and how to differentiate, for example, from blood. you might be able to differentiate on the ultrasound on blood versus empyema as well. Okay. Now, any questions? I'll stop sharing. All right. Any questions?
For consolidation, to be able to pick it means that you have to scan both lungs and different lung zones, I guess.
Yes. Yeah. So now that you can see me, so I start this way. When I scan for the lung, I start apex here and then go mid thoracic and go more towards the base. Okay. And then can go posteriorly in 3 spots, you know, parascapular, infrascapular, and towards the base. And then the same thing on the right side. Okay. Oh, sorry, on the left side. So you have infraclavicular, at the nipple line, and then at towards the base. Okay, so this is how I go scanning. Yep. So for the consolidation, you look from different, as kind of as many areas as possible.
Yeah, and also, is it easier with long axis or short axis when
So
scanning?
transverse. Oh, usually it's when you put the probe. Let's say if I show the probe, I use it the probe, so the curvilinear probe. I use it, you know, to cover. I don't use it like this.
Okay.
I don't use. I put it transverse. So I have 2 ribs in view, and I keep moving like this. Yeah. So I keep like this and then keep down. Yeah. Sometimes you can put, you know, you slant different ribs along different ribs. Yeah. And then you go onto the other side and the same, you go slide. Yeah. Make sense? But usually I save loops. When you save the images, you know, I don't move very quickly. I just scan here, look at the images, identify the normal structure, or if it's not, and then move again, you know, and then move further. Okay. So I evaluate interpret each of the images or the loops that I acquired. Yeah. Makes sense? But I use it transverse. So I use it transverse to the ribs. Okay. Not like this.
Yeah.
Yeah.
Sorry, Claudiu, with the A lines that you mentioned,
Yep.
so will they only be like one layer of A lines? There is no multiple ones going deeper? Is
There
that
are
right?
multiple.
Or
They're usually
multiple
about 3,
parallel?
4.
Yeah.
Yes.
Okay.
So coming back is yes, and that is kind of a yeah. So because it, I was mentioning, is the same effect like having 2 mirrors in the front. Okay, the image keep bouncing. Yeah, and in between you have the soft tissue. And if you put the mirrors, you put it like this. Yeah. So you have the ultrasound. You have the probe at the top, but this is the skin, and air is above, and air is underneath it, the pleura. So the image ultrasound wave comes from the top skin, hits the pleura, and then bounces from the air, comes back to the skin. But once you hit air, it bounces back. So once you goes once like this, it comes. You have pleura. That is the image, and then goes again, and that it creates the depth. And so you have an A line here, and then goes again, bounce it back, and you'd have another A line. So you have usually about 2, 3, and then it loses the intensity. Okay, if you're not sure, coming back, the distance is the same. So pleura and the A line underneath it is the same from the skin, the thickness of the skin or the subcutaneous tissue. Make sense? So it's you have like this, and then underneath it you have an A line, and then another one you have another A line, but it's the same depth. They are parallel and not the same distance.
And when you're scanning a patient's on the posterior aspects, would you scan them upright, or would they be lying down, something?
So
the positioning of the patient, essentially.
Yeah, so it can be either. So it depends on how sick is he. If he's very sick and you can't sit him up, that you don't need to do. Sometimes you can roll him a little bit onto the side. Okay. most of the time, if he's very sick and he's in supine position, you leave it there and you do it. You can do anteriorly and then, you know, mid-axillary. So we're going this way. Okay. If he's in a pulmonary edema, he's not going to like sitting flat in bed. So you're going to sit upright automatically. Okay. If he's in acute pulmonary edema, and it's easier to access the back. Okay. Make sense? For pleural effusion, I prefer to sit them upright because most of it's easier to drain posteriorly. I mean, nowadays it's preferred mid-axillary as well, but most of the fluid accumulates in the costodiaphragmatic space. So posteriorly, it's actually the fold of the pleura is much deeper. So you have a lot of fluid sitting there. So it's makes sense. So usually posterior, I scan for pleural effusion posteriorly as well. And I try to find the one, usually I go two intercostal space above the diaphragm. Okay, so I have a good range of, for fluid drainage. Okay, so I make sure that I don't hit any other organs with it, particularly the liver. Okay, so it can be, it depends on how it allows you the patient, but yeah, posteriorly for pulmonary edema. If you have someone unconscious, then you can go anteriorly as well, or you can go more more lateral side. Okay, mid-axillary area, like for hemothorax, how you treat in the fast, how you do the fast.
Yeah.
Okay, so when you do fast, basically when you do fast and you do extended fast, you go through image the kidney and the liver, and then go higher up. You slide upwards and you look at the lung.
Yeah. If we just got last question out of curiosity, will you be able to use ultrasound? When you use ultrasound, can you detect lung changes in more chronic lung conditions like interstitial lung disease, fibrosis, or anything like that? Yeah.
Yes. So there are yes, you can diagnose. Sometimes it can be, for example, COPD. They can give you this similar kind of what you have in a pulmonary edema. I didn't want to go through this because it can be tricky and confuse a little bit more.
Yeah.
So that is some forms of pulmonary fibrosis can give you same kind of an aspect with pulmonary edema, with acute pulmonary edema. Okay, with APO. So in COVID, you have changes. For example, when you have interstitial lung disease, and for example, how you have it infiltrates in COVID as well. You have multiple aspects. You can have B lines. You can have the pleural irregularities. Okay, so the pleural line is not smooth. You have a lot of irregular surface. You have small in the pleura. In the pleural space, you see also small pleural effusion as well. So you have areas of alternating normal lung with a little bit of B lines, and then with a small, very small pleural effusion. Okay, and so you have a mixture of all the concepts that I introduced. Same for interstitial lung disease. One of the cases was interstitial lung disease, but I didn't go through it because it takes it to a different level. But basically, you have the same variation of signs that you have it with the one that we discussed of.
Yeah.
Okay, but they are a mixture. They will have a mixture of it. Yeah.
Very cool.
So look, I'm sure you guys are going to have lots of good pathology out there. Okay, and I'm really hoping that this way, this is an opening. The purpose is non-receipt from this one is to, some of you might be able to say, yeah, I can diagnose pneumonia or pleural effusion. But again, there's a lot of resources, and just to, I opened the door to the possibility that there's a lot of things that the ultrasound can be used, and to help you, with the lung pathology. All right.